Hello everyone, I'm Professor Kennedy Edom Kukuya, and today we're delving into the intricate world of antipsychotic medications, focusing on their neurobiological and pharmacological mechanisms. So, let's get started. First, let's talk about psychosis. Psychosis is a mental disorder characterized by a disconnection from reality. Symptoms include hallucinations, delusions, disorganized thinking, and impaired insight. The pathophysiology of psychosis involves dysregulation of neurotransmitters, particularly dopamine and glutamate, in the brain. Antipsychotics, also known as neuroleptics, are pivotal in the management of psychiatric disorders such as schizophrenia, bipolar disorder, and severe depression. They are divided into first-generation, typical, and second-generation, atypical, antipsychotics. Examples of first-generation drugs include chlorpromazine, haloperidol, thioridazine, while second-generation drugs include clozapine, quetiapine, risperidone, aripiprazole. Primarily, antipsychotics function as dopamine receptor antagonists. This means they inhibit dopamine receptors, particularly the D2 subtype, in the brain. Dopamine is a crucial neurotransmitter involved in regulating mood, motivation, and cognitive functions. In conditions like schizophrenia, hyperdopaminergia or excessive dopamine activity is often observed, leading to positive symptoms such as hallucinations and delusions. By antagonizing D2 receptors, antipsychotics mitigate these symptoms by reducing dopaminergic transmission. The dopaminergic pathways, particularly the mesolimbic and mesocortical pathways, are crucial in the action of these drugs. The mesolimbic pathway is associated with the positive symptoms of psychosis, while the mesocortical pathway is linked to cognitive and negative symptoms. These agents also modulate other neurotransmitter systems, including serotonin, 5-HT, glutamate, and gamma-aminobutyric acid, GABA. For example, atypical antipsychotics or second-generation antipsychotics often exhibit antagonistic or partial agonistic activity at 5-HT2A receptors, which can ameliorate depressive and anxious symptoms associated with psychotic disorders. Now let's discuss the adverse effects of antipsychotics. One severe adverse effect is neuroleptic malignant syndrome, which is a life-threatening condition characterized by muscle rigidity, fever, and autonomic instability. Another set of adverse effects are extrapyramidal symptoms, which include tardive dyskinesia, a condition involving involuntary repetitive body movements. These symptoms are managed by dose reduction, switching to a different antipsychotic, or discontinuing medications like anticholinergics in tardive dyskinesia. Finally, let's discuss some individual antipsychotics. For example, clozapine is effective for treatment-resistant schizophrenia, but requires regular blood monitoring due to the risk of agranulocytosis. Risperidone is another antipsychotic that is effective but can cause hyperprolactinemia, weight gain, and metabolic syndrome. Each antipsychotic has its own profile of efficacy and side effects, making it crucial to tailor treatment to the individual patient. In conclusion, the neurobiology and pharmacology of antipsychotics are intricate but fundamentally aim to restore homeostasis within the brain's neurotransmitter systems. As ongoing research elucidates these mechanisms further, we can refine our therapeutic strategies to better assist those with severe mental health disorders. Thank you for joining me in this comprehensive exploration of antipsychotics. I hope this has provided a deeper understanding of how these essential medications function at a cellular and molecular level. Until we meet again, this has been Professor Kennedy Edom Kukuya.